Okay, let's unpack this. You've landed here with a stack of information on type 2 diabetes, a really complex topic affecting millions worldwide. If you're feeling a bit swamped by all the research and guidelines out there, you're not alone. And that's exactly the kind of spot we're designed for.
Today, we're going to take a deep dive into one specific, very comprehensive source, the December 2024 update to the Dutch Standard for Managing Type 2 Diabetes. Think of us as your guides, helping you navigate this detailed material.
Our mission is simple but crucial, to pull out the absolutely essential insights, the surprising facts, and those nuanced details that actually matter for understanding modern type 2 diabetes care. This dive is custom tailored for you, the learner, who wants knowledge that's quick to grasp but also genuinely thorough. Let's get to the heart of what's new and important in this latest standard. So where does the journey of managing type 2 diabetes begin according to this guide? It all starts with diagnosis.
Yeah.
How does the standard define and, establish a diagnosis of type 2 diabetes? It's not just about one single test, right?
That's exactly right. The standard is quite specific here. Diagnosis typically relies on repeated glucose measurements. This means, most often, 2 fasting plasma glucose readings of 7.0 millimole or higher, confirmed on 2 separate days. Or, alternatively, a diagnosis can be made based on a single fasting glucose of 7.0 or higher, or a random plasma glucose of 11.1 or higher, if the patient also has clear symptoms of high blood sugar.
Symptoms like excessive thirst or frequent urination, those kinds of things.
Exactly, those classic symptoms.
Okay, focusing on those direct glucose numbers then. And here's an insight that might surprise some people right off the bat, coming straight from the source. HbA1c is not recommended for initial diagnosis in this standard. Why is that distinction so important? Why not use HbA1c?
What's fascinating here is that while HbA1c is, invaluable for monitoring long-term blood sugar control over 2 to 3 months, the standard feels it's less reliable for that initial definitive diagnosis. They prioritize the direct plasma glucose measurements for confirming elevated levels right now.
Right now, okay.
This is likely because various factors unrelated to recent blood sugar levels can potentially influence HbA1c results, making the direct glucose test a clearer snapshot, sort of, for diagnosis day.
Got it. So plasma glucose for the actual diagnosis, HbA1c comes in later for monitoring. Makes sense. What about those gray areas then? The numbers that aren't quite diagnostic but aren't normal either? We hear about impaired fasting glucose.
Right, where the fasting number is between 7.0 and 7.8 millimole.
Or impaired glucose tolerance, where the non-fasting level is between 7.8 and 11.0 millimole, but the fasting number is okay. What does the standard say about these? Prediabetes, essentially.
Yeah, prediabetes. And this raises a really important point. The standard emphasizes a crucial insight here. These aren't just minor numerical quirks. They signal a significantly increased risk, not only for ultimately developing full-blown type 2 diabetes, but critically, they also indicate a higher existing cardiovascular risk right then and there.
Wow, okay, so even before full diabetes, the heart risk is already higher.
Exactly. So for someone found to have these numbers, the guide strongly recommends repeating a fasting glucose check with a lab test after 3 months. If a full diagnosis still isn't met, they should then have a yearly follow-up, and importantly, a full assessment of their cardiovascular risk profile needs to be done. It's a warning sign that requires action.
So even before a formal diabetes diagnosis, these numbers point to a risk profile that needs proactive management.
Right. Moving on, the standard details some really crucial steps right after diagnosis, specifically within 3 months to check for early complications. One area they really highlight is a detailed foot examination. What does that involve, and why is it given such prominence so early?
This is a really critical step because, unfortunately, foot complications are very common in diabetes. The standard specifies a thorough check, looking at the color and shape of the foot, assessing for any deformities like bunions or claw toes, checking nails, looking closely for pressure spots, calluses, cracks, or any existing wounds or amputations. And here's a key detail. They specifically test for protective sensation using a 10-gram monofilament. That's that little flexible wire thing.
Exactly. A fine, flexible filament used to see if you can still feel light touch on 3 key areas under the foot: the big toe, the base of the big toe, MTP1, and the base of the little toe, MTP5.
And they call out that specific sensation test with the monofilament as the single best predictor for the risk of developing a foot ulcer. That's a powerful insight.
It really is.
Yeah.
Because if you've lost that protective sensation, a small pebble in your shoe or a pressure point from ill-fitting shoes can cause an injury you don't feel.
And then it gets bad quickly.
Precisely. It can then rapidly worsen.
Why such a focus specifically on the feet and diabetes? What's the mechanism?
Well, it's because two major diabetes complications are behind many foot problems: nerve damage, known as neuropathy,
Right, neuropathy.
and poor circulation or peripheral arterial disease, where blood flow to the feet is reduced. The standard also mentions checking for pulses in the feet, specifically the dorsalis pedis and posterior tibial arteries. If both are hard to find or absent, that's an indication for further tests, like a Doppler ultrasound, to assess blood flow more thoroughly.
Okay, so this isn't just a one-off check then. This early foot assessment leads to a risk classification, right? The SIMS classification.
That's right, the SIMS classification ranging from SIMS 0 up to SIMS 3.
And that classification directly dictates how often your feet need to be checked in the future.
Exactly. Someone classified as low risk, SIMS 0, might just need checks annually, but someone in the very high-risk category, SIMS 3, needs checks much more often, maybe every 1 to 3 months, and often requiring referral to a specialized podiatrist. It's a structured approach directly linked to that initial risk assessment.
Okay, that makes sense. Very structured. So we've covered diagnosis and those critical early checks. Now, the guide makes something absolutely crystal clear that might sound simple, but is profound. Lifestyle is not just an add-on, it's the absolute basis of treatment for type 2 diabetes. Why is that foundational role so emphasized?
Well, if we connect this to the bigger picture of type 2 diabetes, factors like being overweight and not getting enough physical activity are just deeply intertwined with its development and progression. They aren't just related, they are key drivers. So addressing them directly provides the most fundamental lever for improvement.
And the standard actually puts its money where its mouth is on this, right? I read that for patients with only mildly high glucose and no symptoms, it suggests you might even wait a few months
That's right.
to see the effect of lifestyle changes before starting any medication. That really does underscore the potential power here.
Absolutely. It acknowledges that for a significant group, lifestyle intervention alone can potentially bring blood sugar levels back into a healthier range without needing pharmaceuticals, at least initially.
Okay, let's dive into the core pillars of lifestyle advice outlined in this standard. What's the first, most critical area they address?
Stopping smoking. This is highlighted as one of the single most important modifiable risk factors for cardiovascular disease, which, as we know, is already elevated in type 2 diabetes. And here's a specific insight from the source. Data shows that heavy smokers have a significantly higher risk of developing type 2 diabetes itself compared to lighter smokers.
Really? Independent of weight.
Independent of other factors like BMI, yes. So support for quitting is absolutely essential.
Wow. Okay, beyond smoking, sufficient exercise is the next key pillar. What are the specific recommendations here? Are they just get more exercise?
No, they provide pretty clear targets, actually. They aim for at least 30 minutes of moderate intensity exercise 5 days a week. And if you are overweight, that recommendation goes up to 60 minutes a day.
60 minutes, okay.
Plus, on top of that, they suggest muscle and bone strengthening activities twice a week and actively minimizing long periods of sitting throughout the day. It would break up that sitting time. But the key insight here is also tailoring this advice to your individual possibilities and preferences. It needs to be sustainable for you.
Yeah, adherence is always the challenge. Were there any specific studies mentioned that highlight the impact of exercise?
Yes, a key one referenced is the Diabetes Prevention Program, the DPP trial. This was a large study in individuals with pre-diabetes. It showed that combining exercise with diet resulted in a significant reduction in the risk of progressing to full diabetes, something like a 58% reduction at 3 years compared to a placebo group.
58%, that's huge.
It is. And remarkably, that benefit persisted, maybe lessened a bit, but still there, with a 27% reduction even after 15 years.
15 years later, wow.
Looking at types of exercise, aerobic training seems likely to help lower HbA1c and blood pressure, and it might help with weight reduction. Resistance training might also help specifically with blood pressure. And they mention guided programs can potentially boost motivation and adherence.
Makes sense. Okay, third pillar, healthy nutrition. What's the standard advice on diet? Is it super specific?
The dietary recommendations broadly align with general healthy eating principles, really. Lots of fruits, vegetables, whole grains, regularly including fatty fish and limiting things like saturated and trans fats, added sugars, excessive salt, and alcohol. Pretty standard stuff.
Okay. Anything controversial or new there?
Well, here's an interesting point the source notes, reflecting ongoing scientific debate. There's still no firm consensus in the medical literature on whether a high-carb, low-fat or a low-carb, high-fat dietary approach is definitively superior for everyone with type 2 diabetes.
So the guide doesn't pick a side in that debate.
No, it acknowledges the lack of consensus. This suggests flexibility is probably key based on individual preference and needs, rather than one single best diet.
Got it. And weight loss, which is often a critical goal for many with type 2 diabetes.
Yes, losing weight, particularly through dietary changes, showed positive effects on glucose levels in large foundational studies like the UK-PDS trial. However, that study also highlighted a significant challenge. Maintaining that weight loss over the long term proved difficult for many participants.
Right. The age-old problem of keeping it off.
Exactly.
Finally, on lifestyle, a quick point on supplements. What did the standard conclude after reviewing the evidence for common ones like omega-3 or cinnamon?
Yeah, they looked specifically at those common ones: omega-3, vitamin E, zinc, vanadium, chromium, cinnamon. The consistent finding was basically insufficient reliable evidence to recommend their widespread use in type 2 diabetes management.
And no magic bullet there.
Pretty much. They concluded that focusing on a healthy diet itself provides the necessary nutritional support, and these specific supplements generally didn't demonstrate a clear, consistent benefit on key outcomes in the reviewed studies. For instance, a large trial showed no significant reduction in cardiovascular events with omega-3 supplementation, despite its popularity.
So the insight is to really focus on those fundamental lifestyle changes, backed by solid evidence, before looking to supplements. Okay. Now, if lifestyle isn't enough, or for patients who need more support from the start, medication comes into play. The standard outlines a stepped approach for most patients without very high cardiovascular risk. What's the first step in medication?
Step 1 remains metformin, still the go-to first-line agent.
And here's where this December 2024 update introduces some significant changes. What's the new recommended approach for step 2? This sounds important.
This is where it gets really interesting, yeah. The default recommendation for step 2 is now glucoside, which is an SU derivative. However, and this is the key update, the standard provides important criteria where you should deviate from glucoside.
Deviate, okay.
And start a GLP-1 agonist if the patient's BMI is 30 or higher, or start an SGLT2 inhibitor if they have 4 or more specific cardiovascular risk factors.
Wow, that feels like a major shift, bringing those newer, potentially protective drug classes in much earlier for specific patient profiles, rather than just adding them way down the line. Can you briefly explain what GLP-1 agonists and SGLT2 inhibitors generally do? Just a quick reminder.
Absolutely. So GLP-1 agonists are a class of medications that mimic natural hormones. They help your body release insulin more effectively when blood sugar is high. They reduce glucose production by the liver, slow digestion.
Which can help with feeling full, right?
Exactly, and often lead to weight loss, which is why that BMI cutoff makes sense. SGLT2 inhibitors work differently. They work in the kidneys. They block a protein called SGLT2, which causes the kidneys to remove excess sugar from the blood and excrete it in the urine.
So you pee out the sugar.
Essentially, yes. This lowers blood sugar, but also has significant protective effects on the heart and kidneys, kind of independent of just the glucose lowering.
Okay, that clarity helps understand why they might be considered earlier for certain people. And beyond step 2, how is medication choice approached? Does it get more complex?
Yeah, beyond step 2, the choice becomes highly individualized. It depends on factors specific to the patient, how much further the HbA1c needs to be lowered to reach their target, and their personal preferences, tolerability of different medications, potential side effects, all that comes into play.
Speaking of HbA1c targets, are they the same for everyone throughout treatment? Aim for X and that's it.
No, they're not rigid after step 1. Well, the target is typically 53 millimole after step 1.
Which is about 7% in the older units.
Roughly, yes. From step 2 onwards, the target becomes more flexible. It's adjusted based on factors like the patient's age, how long they've had diabetes, frailty, generally allowing for higher targets in older or more frail individuals to avoid risks like hypoglycemia, low blood sugar.
Right, avoiding those dangerous lows.
But there is a clear consensus on an HbA1c level to definitely avoid anything above 69 millimole.
Why that number?
Because that level is consistently linked to bothersome symptoms like fatigue, increased risk of infections. It's just a threshold where problems really start to increase. So it's about finding that personalized balance.
Balancing tight control with individual safety and circumstances. Makes sense. And it's not just glucose, right? The standard also stresses managing blood pressure and cholesterol.
Oh, crucially. Managing blood pressure with antihypertensive medications and cholesterol, often with statins, follows separate but equally vital guidelines. The standard reinforces an increasing trend across all aspects of diabetes care. It's moving towards becoming much more individualized, tailoring not just medication, but also treatment targets and checkup frequency to the specific person.
That individualized approach makes a lot of sense. Now, you mentioned a very high-risk group for cardiovascular disease having a different medication approach right from the start. Who exactly is included in this updated, very high-risk category? Did that change?
Yes, the update made a specific clarification here. The very high-risk group now includes all patients with heart failure, regardless of their specific ejection fraction.
Regardless of EF, that's a big change.
It is. It's an expansion of the previous definition and really highlights the strong link between heart failure and overall cardiovascular risk in diabetes.
And for this very specific group, what's the cornerstone of their medication plan? Is it still metformin first?
For these patients at very high cardiovascular risk, SGLT2 inhibitors and GLP-1 agonists form the basis of their medication treatment plan. Metformin might still be used, but these protected classes are key. The standard strongly advises considering these protective medications early on for their documented benefits on heart and kidney outcomes, even if the patient's HbA1c is already well controlled, like at 53 millimole or lower.
So the focus shifts more to direct organ protection.
Exactly. The focus shifts to cardiorenal protection alongside or even sometimes prioritizing over just glucose control in this specific group.
Okay. Let's briefly touch on some specific points the standard makes about the different medication classes we've mentioned. Starting back with metformin, the usual first step. Any key takeaways there?
For metformin, the standard offers practical tips like starting with a low dose and increasing gradually to help manage those common gastrointestinal side effects like stomach upset. But a really crucial warning emphasized is the need to temporarily stop metformin during episodes of severe dehydration.
Like from vomiting or diarrhea.
Exactly. This is especially important if kidney function is reduced due to the rare but serious risk of a complication called lactate acidosis. That's a key safety point.
Got it. How about the SU derivatives like gliclazide, which is the default step 2 for many?
Gliclazide is the preferred choice among the SU derivates compared to others like glimepiride or tolbutamide. The main reason is it has a lower risk of causing hypoglycemia or dangerously low blood sugar. The standard strongly discourages glibenclamide specifically due to its significantly higher risk of serious hypoglycemia. Avoid that one if possible.
Good to know.
And it also notes that different formulations of gliclazide aren't always interchangeable. And if someone on gliclazide is having frequent documented low blood sugar episodes, the standard recommends stopping it and considering other options.
Right. What about the GLP-1 agonists, the class used earlier now for certain profiles, usually injections, right?
Yes, these are typically administered by injection. The standard notes that currently available oral versions aren't the preferred choice.
Why not? Convenience seems good.
Partly because the evidence for their cardiovascular protection isn't as robust yet as for the injected forms, and their absorption can be less predictable. So injections are generally preferred for those benefits. Also, if a patient is also taking insulin or certain other medications, dose adjustments might be necessary when adding a GLP-1 agonist to avoid lows. And there's a specific caution mentioned with semaglutide in patients using insulin who have existing retinopathy, eye damage, as there's a possible risk it could worsen. Something to monitor closely.
Okay. And don't combine them with DPP-4s.
Exactly. They explicitly state not to combine GLP-1 agonists with DPP-4 inhibitors, as they target similar pathways and don't offer additive benefit, just potential added side effects or cost.
And the SGLT2 inhibitors, known for their protective effects, especially in the very high-risk group. Any specific warnings there?
SGLT2 inhibitors are indeed highlighted for those heart and kidney benefits. However, the standard also includes a warning about a rare but very serious potential side effect, a severe necrotizing infection called Fournier's gangrene.
Oof, that sounds nasty.
It is. It occurs mainly, though not exclusively, in men. It's a critical side effect to be aware of, even though it's rare. Patients need to know the signs.
Okay. What about the DPP-4 inhibitors? You said don't combine with GLP-1s. Anything else?
Yeah, besides not combining them with GLP-1 agonists, the standard also advises awareness of potential associations with pancreatitis and a specific increased risk of severe heart failure noted with saxagliptin, and caution regarding severe kidney issues with sitagliptin in certain patient populations. So some specific drug warnings within that class.
And lastly, insulin, if it becomes necessary down the line. Which types are preferred according to this standard?
If insulin is required, the preferred long-acting types, or basal insulins, are NPH insulin, or insulin glargine 100 ml. The standard weighs their pros and cons. Glargine 100 might lead to fewer
which is convenient.
Definitely.
Mm.
While MPH is generally less expensive, so there's a trade-off. Other long-acting types like Detamir, Digludec, or the higher concentration Glargine 300 are not the recommended first-line options in this standard, maybe reserved for specific situations.
Why not? Are they less effective?
Not necessarily less effective, but the standard might prioritize based on long-term data, cost effectiveness, or specific risk profiles.
Yeah.
There's also a nuance noted about the longer-term safety data being more extensive for the older insulins like NPH and Glargine 100 compared to some of the newer formulations.
Okay. The guide also includes a table showing the typical expected HbA1c reduction from each drug class, which must be a helpful tool for doctors deciding what to add next, right?
Exactly. It provides an estimate of the glycemic potency, how much each drug class can typically lower blood sugar on its own. That's important for titrating treatment to reach an individual's target HbA1c.
On the topic of complications, the standard makes an interesting point about protecting the small blood vessels, the microvasculature, in places like the eyes or kidneys. What's the key insight there regarding different drugs?
Yeah, this is fascinating. It's a conclusion drawn from analyzing the evidence. While different medications have varying effects on major cardiovascular events like heart attacks or strokes, where SGLT2s and GLP-1s show benefits, the standard concludes that all glucose-lowering medications are considered equivalent in their ability to protect against microvascular complications.
All of them, equally.
Yes, equally protective against damage to the eyes, retinopathy, or kidneys, nephropathy. The crucial factor appears to be achieving good blood glucose control, and any of these medications can help achieve that. So they're considered equally protective against these specific small vessel complications if they get the job done on lowering glucose effectively.
That's a really key distinction to understand the focus of different drugs can vary. Big vessel protection versus small vessel protection.
Exactly.
The standard also discusses the balance of intensive treatment, referencing major studies like UKPDS and ACCORD. What were the big takeaways from those trials regarding how aggressive to be with glucose lowering? Is lower always better?
Not necessarily. The UKBDS study, a landmark trial, showed that intensive glucose lowering, started relatively early after diagnosis, could reduce the long-term risk of microvascular complications effects seen even 20 to 25 years later.
So long-term benefits for eyes and kidneys.
Yes. However, later studies like ACCORD showed a cautionary tale. Aiming for very aggressive, very low HbA1c targets could potentially increase the risk of overall mortality.
Increased mortality. Why?
The reasons are complex, but it seems strongly linked to the risk of severe hypoglycemia events, those dangerous lows in that very intensively treated group. So the standard emphasizes finding a balance. It also notes that intensive glucose control has consistently not been shown in major studies to reduce the risk of cancer incidence or mortality. That link just doesn't seem to be there based on current evidence.
So it's about avoiding the long-term microvascular damage, but also avoiding the immediate, potentially dangerous risks of aiming too low with blood sugar. A balancing act.
Precisely.
Circling back to that step 2 change, we talked about recommending SGLT2 inhibitors or GLP-1 agonists earlier for some non-very high-risk patients. The standard goes into detail about the reasoning. What's the argument for targeting this specific subgroup earlier, even if they aren't technically very high risk?
Right. The core argument is identifying a specific subset of patients within the broader low to moderate risk group who have a specific clustering of poorly controlled risk factors. This clustering elevates their overall cardiovascular risk significantly, even if they don't meet the strict, very high-risk definition based on, say, having had previous heart attack.
What factors make up this cluster?
The standard names 5 specific factors they looked at: active smoking, therapy-resistant, high blood pressure, meaning it's hard to control even with meds, high LDL cholesterol despite medication, being age 60 or older, and having mild chronic kidney damage, like slightly reduced eGFR or microalbuminuria.
Okay, so a combination of those things.
Yes. The insight is that for patients with 4 or more of these specific factors, the potential protective benefit of SGLT2 inhibitors or GLP-1 agonists on heart disease outcomes is considered substantial enough to warrant bringing these medications in earlier than a purely glucose-driven approach might suggest.
Even if their HbA1c isn't super high.
Potentially, yes. It's a targeted intervention for a subgroup thought most likely to benefit from the specific cardiorenal protective effects of these drug classes, even if the numbers needed to treat aren't quite ideal for the entire low-risk population.
Okay, that clarifies the nuance. It's not just about blood sugar in that case, but identifying a specific higher risk profile within the non-very high-risk group. Makes sense. Shifting gears now, diabetes can impact many parts of the body. The standard touches on several key potential complications and related conditions. Let's start with chronic kidney damage, or CKD. How is that defined here?
CKD in the context of diabetes is defined by a reduction in kidney function, often measured by something called eGFR, the estimated glomerular filtration rate.
The kidney function number.
Right. And/or the presence of increased protein in the urine, known as albuminuria, that persists for at least 3 months. The standard highlights its extremely close relationship with cardiovascular disease. They share many common risk factors like smoking, high blood pressure, high cholesterol. They essentially run hand in hand.
And there was a finding mentioned about CKD risk that felt particularly striking, related to earlier life.
Yes, the source pointed to a strong link between being overweight or obese during adolescence and a significantly increased future risk of end-stage renal disease, needing dialysis or transplant.
Wow, that far back.
Yes. And what was particularly notable is that this link was found to be independent of other factors developing later. That really underscores the long-term impact of weight status much earlier in life on kidney health.
That's sobering. Sexual dysfunction is also acknowledged as a frequent issue in diabetes.
It is, unfortunately. The standard provides data showing it's quite common, particularly in men, where prevalence figures are given. In women, issues like reduced lubrication are noted as frequent, and psychological factors, especially depression, seem to play a particularly significant role for women's sexual health in diabetes.
So it's complex.
Very much so. It's often not just one thing. It's usually multifactorial, linked to factors like age, how long someone has had diabetes, how well their glucose is controlled, the presence of other complications like neuropathy or vascular issues. Treatment involves optimizing diabetes control and addressing any related health issues, plus specific treatments like medication for erectile dysfunction in men when appropriate.
People with type 2 diabetes also seem to be at higher risk for infections compared to the general population. Is that covered?
Yes, that's noted in the standard. The increased susceptibility to various infections is a known complication of diabetes. Higher blood sugar can impair immune function.
And the standard also touches on cancer risk. What's the connection there?
Yes, the source indicates an increased risk of certain cancers in people with type 2 diabetes. This includes cancers of the pancreas, liver, and colon, among others. There seem to be some slight differences in risk profiles between men and women for specific cancer types.
Any cancers with lower risk?
Interestingly, yes. One large study referenced actually found a lower risk of prostate cancer in men with diabetes. The reasons aren't entirely clear. And we also circled back to the point from earlier studies that intensive glucose control itself has not been shown to reduce cancer incidence or mortality risk. Lowering sugar doesn't seem to lower cancer risk directly.
Right. Finally, on complications, a serious but thankfully less common one mentioned, Charcot foot. What is that?
Charcot foot is described as a rare but very severe complication. Neuropathy, that nerve damage we talked about, is a key factor. Because sensation is impaired, a seemingly minor injury, like twisting an ankle slightly or stepping on something small without realizing it, can trigger a severe inflammatory reaction in the foot bones.
Inflammation in the bone.
Yes. And due to the lack of pain sensation, the person might continue to walk on it, unaware of the damage happening. This leads to rapid bone damage, fractures, and collapse of the foot structure, causing severe deformity.
That sounds awful.
It is. Immediate recognition and treatment, often involving complete immobilization in a cast or special boot to take all pressure off, are absolutely critical. If it's not recognized and treated quickly, it can lead to severe deformity, chronic non-healing ulcers, and, unfortunately, sometimes amputation. Early detection is absolutely paramount.
That's a sobering reminder of the potential impact of neuropathy. Okay. We've covered diagnosis, lifestyle, medication, and potential complications. How does the standard approach finding undiagnosed diabetes in the population and educating patients on managing their condition?
Right, finding new cases. The standard notes that widespread population-wide screening for type 2 diabetes isn't recommended in the Netherlands.
So not screening everybody over a certain age.
No. Instead, they favor targeted case finding. This means opportunistically screening individuals who are already identified as being at higher risk when they interact with the healthcare system for other reasons.
Makes sense. Focus the resources. Are there specific higher risk groups they recommend screening earlier?
Yes. The standard mentions certain groups warranting earlier consideration for screening. For example, people of Hindustani descent, where screening is recommended starting at age 35 due to a high prevalence of diabetes in that population group, and also individuals with hypertension or high blood pressure.
Okay. Does the standard say that finding it early definitely leads to better outcomes?
Actually, the standard acknowledges a key insight here. There isn't definitive, strong evidence demonstrating that early diagnosis and treatment through screening necessarily lead to better long-term health outcomes for absolutely everyone who is screened and found to have it early. The evidence is a bit mixed on that broad question.
That's an important nuance, definitely. Speaking of risk factors, what about a history of gestational diabetes during pregnancy?
Yes, experiencing gestational diabetes during pregnancy is a significant risk factor for developing type 2 diabetes later in life. The standard highlights that the highest risk period is in the first 5 years after delivery. Because of this, follow-up and potentially screening after pregnancy are crucial for these women.
Good point. Now, education is clearly vital for managing a chronic condition like this. What insights does the standard offer on different approaches to patient education? Group classes, individual.
The standard reviews the evidence for both individual and group-based education programs aimed at helping patients manage their diabetes themselves, often called self-management education. Studies on group education show mixed but sometimes positive effects on factors like glucose levels, blood pressure, and weight, although the sustainability of these effects varies long-term. A specific Dutch course was mentioned that showed some short-term benefits on BMI and blood pressure.
What about other approaches, like peer coaching?
Interestingly, peer coaching by experienced patients didn't show broad effectiveness in the reviewed literature, and motivational interviewing, a specific counseling technique, had mixed results as well.
So what did seem effective?
Nurse-led self-management education did show a consistent, albeit modest, average HbA1c reduction in a meta-analysis. It seemed particularly beneficial for older patients. So the overall insight is that education is important for empowering patients to manage their condition, and it can even help some patients delay or avoid the need for insulin therapy down the road.
Right. Another area that's becoming increasingly important is remote care, using technology like video or phone calls for checkups. Telehealth. What does the standard say about that?
Yeah, telehealth is definitely relevant. The standard examined the evidence for checkups conducted via video, phone, or e-consult, sometimes involving patients sending in their own glucose or blood pressure measurements.
What do patients think?
Patient feedback noted advantages, like convenience, saving time, and less travel. But some patients expressed missing the personal contact of face-to-face visits. That personal connection is important to some.
And what about the outcomes? Does it work as well?
Looking at the research, a meta-analysis suggested that remote care likely leads to improvements in HbA1c and systolic blood pressure, and it possibly increases quality of life and a sense of self-efficacy, that feeling of being able to manage your condition.
Okay, so some positives. Any downsides or unknowns?
Well, the evidence is uncertain or showed no significant difference for more crucial hard outcomes like mortality, major diabetes complications, or hospitalizations related to severe high or low blood sugar. So while it might help with some numbers and feelings, the jury is still out on whether it impacts the really big long-term outcomes. The standard notes that the costs and long-term effectiveness of remote care models still need more research.
That gives us a good picture of how the standard approaches finding new cases, supporting patients through education, and the potential role of technology. There's also a relatively newer section in the standard on type 2 diabetes being in remission. That sounds like a really positive possibility. How does the standard define remission?
Yes, it's an encouraging development. It's defined quite specifically as having normal glucose and HbA1c levels. That means a fasting glucose consistently below 7 millimole A&D and HbA1c consistently below 48 millimole.
Back to normal levels.
Exactly, for a significant period, at least 3 months, and crucially achieving and maintaining this without needing any diabetes medication.
That's fantastic news for anyone who reaches that point. Sounds like a cure.
Well, and here's the really important caveat the guide includes. What's the key insight about being in remission?
Okay, what's the catch?
Yes, this is a critical point the standard wants to emphasize. While achieving remission is positive and a major accomplishment, the risk of serious complications, specifically retinopathy, eye damage, nephropathy, kidney damage, and neuropathy, nerve damage, and the increased risk of cardiovascular disease still remain.
Even with normal blood sugar off meds?
Even then, remission doesn't erase the underlying predisposition or the history of elevated glucose entirely and the damage that might have already started.
So it's not a cure in the sense of eliminating all future risk, but a state of control without medication. What follow-up does the standard recommend for someone who achieves remission? Do they just stop coming for checks?
No, definitely not. The standard recommends continuing annual checkups for a period of 5 years after remission is confirmed. These checkups should include repeating the glucose and HbA1c measurements to ensure blood sugar remains normal, and importantly, continuing to screen for those potential complications we just mentioned: eyes, kidneys, feet, cardiovascular risk.
And does remission always last?
Unfortunately, no. The standard also acknowledges that hyperglycemia, elevated blood sugar, often returns. This can be due to factors like weight regain, stress from other illnesses, or simply the natural ongoing decline in the function of the insulin-producing beta cells over time, which is part of the disease process for many.
Right, okay. Bringing all of these pieces together then, diagnosis, lifestyle, medication steps, the complications, screening, education, technology, and even remission, what's the overarching big picture message from this comprehensive standard?
Well, if we connect all these dots, the standard confirms that achieving good diabetes control is a realistic goal for a large proportion of patients, particularly within primary care settings. It is achievable, but it strongly emphasizes that factors like a history of heart disease or existing kidney damage significantly influence a person's long-term health outcomes and life expectancy.
Hmm.
Those comorbidities matter hugely. Looking at different ways healthcare is organized, like delegating tasks to practice assistants using computer support, studies have shown mixed results, sometimes improving things like cholesterol and blood pressure more effectively than HbA1c levels, interestingly.
And if you had to sum up the dominant trend or philosophy in this latest update, what's the main direction things are heading?
I'd say the strongest overall theme is a clear and deliberate move towards increasingly individualized care. It's about moving beyond a one-size-fits-all approach and truly balancing treatment targets, leveraging lifestyle interventions, making tailored medication choices based on risk profiles, and focusing on complication prevention based on each patient's unique profile, their specific risks, any other health conditions they have, and crucially, their own preferences and goals.
Wow, that was quite the journey, unpacking the latest comprehensive guide on type 2 diabetes care. We started right at the very beginning with how it's diagnosed, clarifying which tests are front and center and which aren't for that initial step.
Mm.
We walked through the absolute foundational and powerful role of lifestyle changes, navigated the updated medication steps, and got into the specifics of key drug classes. Quite a few details there.
Definitely a lot to cover in the medication section.
Yeah, we explored the many potential complications that can arise across the body and even looked at newer areas like the role of remote care and the fascinating but clearly nuanced concept of remission.
It's clearer than ever that this is a complex, multifaceted condition. Managing it well involves understanding not just blood sugar numbers and the guidelines on paper, but the nuances. Knowing when lifestyle is the primary focus, which medications are truly the right choice for which patient based on their individual risk profile and other conditions, and what specific risks, both from the condition itself and the treatments, to be aware of. It's a lot for both patients and doctors to navigate.
So, what does all of this mean for you, the listener, as you process this information? Here's a thought to leave you with, building on everything we've just explored. Given that the risk of serious complications can persist even after achieving remission without medication, and considering that while intensive glucose control is beneficial for preventing small vessel damage, major studies haven't shown it prevents all major risks like cancer and can introduce new dangers like severe hypoglycemia. How do we, as individuals with diabetes and as partners with our healthcare providers, truly find that optimal, delicate, and highly individualized balance of treatment, lifestyle, and vigilance that best navigates the lifelong journey of type 2 diabetes for each unique person? Something to think about.